Welcome to today's webinar, Understanding Men's Health in Down Syndrome. Thank you for joining us. My name is Laura Crone, and I'm the Project Manager for Research and Education at the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois. Next slide, please. We are a clinic for adolescents and adults with Down syndrome, ages 12 and older. Since opening in 1992, our healthcare professionals have seen over 6,000 individuals with Down syndrome. Our team includes physicians, an occupational therapist, licensed clinical social worker, patient advocates, and support staff who serve the physical, mental, and social health needs of individuals with Down syndrome. In addition to providing patient care, we offer a variety of research and education opportunities such as this webinar, as well as our online resource library. Next slide, please. Our online library contains nearly 500 articles, visuals, videos, and other resources related to health and well-being of individuals with Down syndrome. You can access it free of charge at adultdownsyndrome.org, and I will also put the link in the chat. Next slide. Before I introduce Dr. Chicoine, I have a few reminders. This webinar is being recorded, and the link to the recording and the slides from the webinar will be emailed to all attendees within 1 week. There will be a Q&A at the end of the presentation. Please feel welcome to submit questions throughout the webinar using the Q&A option. We will address as many of them as we can. And additionally, if you requested a certificate of attendance, you will receive an email with the certificate within 1 week. Next slide. Our presenter today is Dr. Brian Chicoine. He is the co-founder and medical director of the Adult Down Syndrome Center. He is also on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. In the interest of time, I'm going to share his full bio in the chat, or you can use the QR code to see his bio on our resource library. Thank you for being here, and with that, I'm going to turn it over to Dr. Chicoine.
Thank you, Laura, and welcome everyone. A pleasure to be with you today. So just sort of a informational piece before we start. This is meant to be educational, not meant to replace information or healthcare that you would get provided through your healthcare professional. But certainly this is information that we encourage you to use for yourself as well as share with your health professional in the care of your loved one with Down syndrome. So what we're going to look at today, we're going to look at some conditions in people with Down syndrome that are unique to males, and also some of those differences then in those conditions between males with and without Down syndrome. We're going to define some differences or similarities in health conditions experienced by men and women with Down syndrome. And we're going to describe some health screenings, signs and symptoms to watch for, and practical ways to support health and well-being. So we're going to start with health conditions present only in males, and then we're going to look at the similarities and differences between men with, or males with and without Down syndrome. So start with fertility, and then we got a lot of questions ahead of time about fertility. The research shows that fertility rate is decreased for males with Down syndrome, but there are reports of males with Down syndrome fathering children, so it's not completely infertile. One article reported that about 1% of males with trisomy 21 have fathered a child, and about 7% of males with mosaic Down syndrome have fathered a child. For those of you not aware, mosaic Down syndrome is a situation where not all the cells have trisomy 21. Not all the cells have that extra 21st chromosome in the body. And then theoretically, a male with Down syndrome who fathers a child, about 50% of the children will have Down syndrome themselves. So their offspring will have trisomy 21, have that extra 21st chromosome. So the key point here is that males with Down syndrome have reduced fertility, but they can father children. So they're not would not be considered completely infertile, and certainly that would need to be considered if the individual is having sexual activity. And then another common question is about testosterone. So testosterone is sometimes referred to as the male sex hormone, although women have testosterone as well, although not as much as men. And conversely, men have estrogen and progesterone, but not as much as women. So they're not, it's not either or. It's just amounts that more involved with being a male or female. It's commonly lower in men with Down syndrome compared to men without Down syndrome. So the testosterone level tends to be lower in men with Down syndrome. And lower testosterone may contribute to reduced fertility and may also impact bone density, may contribute to lower bone density, osteoporosis. Neither of the implications of low testosterone, reduced fertility and lower bone density, nor the risks or benefits of treating with testosterone are well studied in men with Down syndrome. So we just don't have a lot of good information on what the implications are of treating men with Down syndrome with testosterone. Should also add that one of the potential side effects of testosterone is aggression, and then when I've had conversations with people, families, and people with Down syndrome, that's always something that they certainly take note of, and certainly may impact whether they decide to consider treatment or not. So again, from a take-home standpoint, testosterone levels may be lower in men with Down syndrome compared to men without Down syndrome, but the implications of low testosterone are not well studied. So we don't have real good information on what the implications of that are, or the implications for treating and replacing it are. Another common question is about undescended testicle. So the medical term is crypt orchidism, and what that means is that the testicle is not down into the scrotum. So this may be present at birth, but it also can ascend out of the scrotum after birth. And in the non-Down syndrome population, the average age is about 8, and there isn't good data on men with Down syndrome, boys with Down syndrome. So just looking at the man here on the picture, so before we're born, before men are born, the testicles are actually in the pelvis. I'm sorry, in the abdomen. So they're within the abdomen or in the pelvis, not dissimilar to ovaries in women. But the difference is that before birth, typically, the testicle will come down. There's a canal here, just at basically at the top of the leg, in the inguinal area. There's a canal called the inguinal canal, and the testicle comes down and then goes down into the scrotum, and then essentially that canal closes. And so there are obviously blood vessels and whatnot attached to the testicle, but that canal closes around that, so it fits snugly around those blood vessels and whatnot. Sometimes that canal does not close, and the testicle can go back up, or sometimes the testicle never came down. So the frequency of this undescended testicle is thought to be about 6.5 to 15% in men with Down, or boys and men with Down syndrome, and in people, males without Down syndrome, it's only 1 to 5%. So significantly more common in males with Down syndrome. So why is it more common? Not really clear. Thought to be that maybe it is a direct effect of expression of some of the genes on the 21st chromosome. And there's also some sense that the decreased muscle tone and connective tissue differences may contribute as well. And so why would that even be important? So certainly it further increases the risk of testicular cancer, which we're going to talk about in just a second. And it also further impairs fertility. So typically this is diagnosed on a physical exam. And since the testicle or testicles can ascend, even if it was present at some point, ongoing exams are recommended, even if it had been palpable, even if it was there in the past and you could find it on the physical exam. And then an ultrasound can also help make the diagnosis if the testicle, it's not clear that the testicle is present or not. Treatment typically is something called orchiopexy, and this is surgically bringing the testicle down into the scrotum and basically then attaching it inside the scrotum so it doesn't go back up. And typically it's recommended to do this between age 6 and 12 months of age, but no later than 18. And again, this is much more studied in boys without Down syndrome than it is in males with Down syndrome. If it's palpable, if it can be felt, either in the scrotum or the inguinal, if it can be felt, and it's not in it's not in the scrotum, but it's in the canal, perhaps. Sometimes you can feel it through the skin. And typically, you can do a surgical approach, either through the scrotum or through the inguinal canal, and then pull it back down and again, tack it down, if you will. If it's not palpable, which means it's more likely within the abdomen, and hopefully you've been able to decide that, or hopefully you've been able to see that on a scan, oftentimes a CAT scan, to see that the testicle is actually there rather than the person doesn't have one. And then in that way, then typically it's a laparoscopic approach, with small incisions, putting the scope inside the abdomen, and then moving the testicle down into the scrotum, and then again tacking it down so it doesn't go back up. So a common question is, what if it wasn't treated in childhood, or if it ascended in childhood but was not discovered until adulthood? So basically, we now have an adult male with Down syndrome, and we're just now really figuring out that the testicle is not in the scrotum where it belongs. So the general recommendation, again, this is mostly studied in people without Down syndrome, but the general recommendation is then to do an orchiectomy, remove the testicle, because again, it's thought that this is increased chance of developing testicular cancer. An alternative is to do an orchiopexy, again, to bring that down, to do a biopsy at that time, and then bring it down and tack it down. And again, the thinking there is that now it's very palpable. You can feel it. You can check it each year, or even more frequently, depending on your approach, and making sure that the testicle is not changing, is not developing cancer, or if it is developing cancer, to find it as early as possible. And again, the biopsy at the time of the procedure is just to make sure that the person already doesn't have cancer. You don't want to pull that testicle down if it's already developing cancer. You want to remove it. Another question is, well, I don't want to put my son or daughter, or my son or daughter, my male child, I don't want to put them through this surgical procedure, or the individual with Down syndrome, I don't want to go through a surgical procedure. So what if no surgery is preferred? There is no consensus recommendation. Again, the recommendation is to remove the testicle in that situation. But if they decide not to surgery, there's no clear-cut answer to that question. Generally, if it's palpable, example, if it's in the inguinal canal there, and you can still feel it, but it's not in the scrotum where it belongs. Sometimes a physical exam, at least every year, is good. And if it's changing size or it becoming more firm or something like that, certainly then you'd want to proceed. But if it doesn't seem to be changing, continue to monitor on a regular basis. Sometimes imaging is recommended, an annual ultrasound, if it's palpable. And so again, taking a closer look at the testicle if it's in the canal, and get a good sense to make sure that there's no changes that would suggest that that testicle may be developing cancer. And then if it's in the abdomen, an annual CT scan or MRI would be done to make sure that it's not changing. Also, sometimes blood tests are recommended. There are things called serum tumor markers, blood tests that tend to go up when someone has developed testicular cancer. So that would be another way to consider to monitor, and as well as looking at testosterone, FSH, and LH, which are again different hormones in the body. It should be really understand that surveillance does not reduce the cancer risk. It just increases the likelihood of diagnosing it sooner, because you're actually able to look at the testicle or feel the testicle with an exam or an image, ultrasound, CAT scan, whatever, and you're actually able to just find it earlier. Hopefully you're able to find it earlier to then do a more definitive treatment. So again, cryptorchidism is more common in men or males with Down syndrome, and we recommend assessing during an annual physical exam to check for that. And again, the biggest issue around this is testicular cancer. So I mentioned that having an undescended testicle increases your chance of getting testicular cancer, and testicular cancer is cancer of one or both testes. Usually affects only one testicle, but it can occur in both. And there are multiple possible cancer cell types. So testicular cancer is not one cell type. There can be various types that someone may develop. And this is seen in males with and without Down syndrome. So that's not unique to one or the other. Age range seems to be similar to those without Down syndrome. So it's typically 15 to 45-ish. Certainly some younger, some older, but that would be the most typical range. The key here, though, is that men with Down syndrome, it occurs approximately 2 out of 1,000. And this is about 2.5 to 4.25 times more common than men without Down syndrome, depending on what study you read. So this is sort of all this information about cryptorganism, the undescended testicle, and testicular cancer. This is one of the few solid tumors that are more common in people with Down syndrome, testicular cancer. So that's why there's so much discussion about this. Why is it more common in males with Down syndrome? Certainly the cryptorchidism, the undescended testicle we talked about. And there are also some maturation delay of germ cells, which are some of the cells within the testicle, as well as some elevated hormones and effect of the gene, the differences in the frequency of the genes because of they having the extra chromosome. So all those seem to contribute to increased risk of cancer. So the long and short of it is, even if someone did not have an undescended testicle, they can still develop testicular cancer. Just having Down syndrome increases your risk, but having an undescended testicle increases it even further. And so why is that important? Testicular cancer, again, is really the only solid tumor noted consistently to be more common in males with Down syndrome compared to males without Down syndrome. Most solid tumors are less common in people with Down syndrome, such as breast, colon, and brain. So this is kind of a unique situation in men with Down and people in Down syndrome in general, but specifically men. So for the non-Down syndrome population, or for the whole population, basically what the United States Preventive Service Task Force recommends, it actually does not recommend routine screening for asymptomatic adolescents and adult males, meaning if there's no testicular symptoms, that they don't recommend an annual exam. And so really the thought is, again, in those without Down syndrome, that we rely on self-report. Male discovers that there's a change in his testicle and hopefully reports that to the doctor. And they found that screening does not change the outcomes. So, typically men will, present and report that there's a change. But in males with Down syndrome, we recommend a different screening recommendation because first, there's limited self-report. So we've had men with developed testicular cancer who had some pretty sizable tumors and that were found on an annual exam, but they were not self-reporting in the interim. And so despite there being clearly a difference, they did not report that. And so what we see, what studies have shown is that testicular cancer may present later in the course of the disease in males with Down syndrome compared to males without. So again, it's more common, and they may not be reporting it as early. And so there is the concern that perhaps testicular cancer will be discovered in a more advanced stage in males with Down syndrome compared to males without. So as far as the global guidelines for adults with Down syndrome, the next version is pending, and this will be part of the recommendation, but that the recommendations have not been published yet. And in our approach at the Adult Down Syndrome Center, we do an annual testicular exam by a healthcare professional to assess for testicular cancer. So again, it's typically it can be diagnosed pretty well on a physical exam, but then if the physical exam is abnormal, you oftentimes order an ultrasound, perhaps blood tests, a serum tumor, these serum tumor markers I mentioned, CT scan or an MRI, and typically we're referring them to a urologist for further evaluation. And again, the treatment typically is a surgical removal of the testicle, which is called a radical inguinal orchiectomy. And the pathology is then done to study the testicle to confirm the diagnosis. Different than a lot of tumors, there is no biopsy of the testicle before it's removed. And so why would you do that? What if there's not cancer there? Because it's been found that if you cut into that testicle to do that biopsy, and the person does have testicular cancer, you increase the risk that it's actually going to spread. And so the treatment then is typically removal of the testicle and then doing the biopsy afterwards, even after it's all been removed. Obviously, you're not going to put it back, but it's, so that's why that's done. And then additional treatment may include chemotherapy or radiation therapy. And the cumulative 10-year survival exceeds 90%. So that's a real important point for this, and certainly why we encourage wanting to make sure we're checking for this and diagnosing it, because the survivability of this cancer is very high. There are not specific Down syndrome data compared to the rest of the population, so we use this similar data. But so again, it found, particularly found earlier, that the chance of survival is very, very high. So again, testicular cancer is more common in males with Down syndrome, and we recommend at our clinic an annual testicular exam to screen for it. And testicular cancer tends to be treatable and usually curable. Another kind of cancer that is only in men is the prostate cancer, and so age range is not well defined for males with Down syndrome. In the non-Down syndrome population, this is typically a disease of older men, although it can, in certain situations, be younger men, but more commonly in older men. Uh, Very low frequency in men with Down syndrome or males with Down syndrome, only 0.2%. And in study we did, males with Down syndrome had a 91% less, were 91% less likely to get prostate cancer compared to males without Down syndrome. So the risk of prostate cancer was only 0.09 compared to males without Down syndrome. So much less common. So there are no data, however, to indicate screening for prostate cancer it should be different in males with Down syndrome. So despite that much lower frequency, there is no clear data that suggests the screening should be different. So that needs to just be taken into account in the discussion. Also, unfortunately, people, males with Down syndrome included, have lower life expectancies. So again, prostate cancer typically being a disease of older men, to being able to screen for it at an older age, and may not have the benefit because the life expectancy of the person with Down syndrome is shorter already. The other thing is that prostate cancer tends to be slower growing, and so you in a lot of sense to find it late in life, you may not really make a difference if it's treated because it is slow growing. And for any of us, as we get older, there's an increased likelihood of unfortunately dying of something else, and the prostate cancer not ultimately being involved in the person's mortality. And so it's that all that has to be included in the discussion of whether screening for prostate cancer makes sense for a male with Down syndrome. And then the other piece is family history, which we know certainly impacts prostate cancer in males without Down syndrome. We just don't have the data to tell us what family history, how that impacts. So as this decision is being made, there are a lot of pieces to the puzzle that we don't have answers to at this point. And so really sitting down and having a discussion with the health professional and what seems to make most sense for you. Um, so there's no data to indicate treating for prostate cancer differently in males with Down syndrome compared to males without Down syndrome. We just don't have the data to tell us whether, what the long-term impact of surgery or medications or whatever, chemotherapy, radiation, what that impact on males with Down syndrome is. So again, for prostate cancer, there are limited data on screening for and treating prostate cancer in males with Down syndrome, and the Adult Down Syndrome Center discusses the low risk and that screening may not be indicated. And for those that are not patients of our clinic, we recommend discussing this with your healthcare professional. So let's shift to conditions that can be experienced by both males and females, and what are some of the similarities and differences between males and females with Down syndrome. So this is people with Down syndrome, males and females, are there differences? So as far as life expectancy, we do know that life expectancy of people with Down syndrome has increased dramatically in the last 100 or so years, going from less than 10 in 1907 to close to 60 now from the data that we have, most recent data we have. There are some slight variations between males and females. So a study in Australia reported males lived a little longer compared to women, females with Down syndrome, which is actually the opposite of the rest of the population. And also there's a slightly higher death rate for females less than 20 years of age compared to males. So again, there is not huge differences, but there may be some difference in the life expectancy with men living a little longer. In general, both men and women, males and females with Down syndrome, people with Down syndrome are living longer and healthier than any time in the past. And so, again, there might be some mild changes, but overall, there's been a significant increase in life expectancy. Just muscle mass. Adults with Down syndrome have less muscle mass than those without Down syndrome. So men and women have lower muscle mass than men and women without Down syndrome. Males with Down syndrome have a higher lean muscle mass and lower fat mass than females, which is similar to the rest of the population, a higher muscle mass in males compared to females. And compared to males without Down syndrome, males with Down syndrome have less muscle and poorer quality muscle, which means more fat in the muscle, less strength, reduce, and which can cause increase or reduce balance. I should reduce balance ability, and more fatigability. And so, again, compared to males without Down syndrome, males with Down syndrome do have lower muscle mass as well as a lower quality of muscle mass. On a positive note, muscle mass and strength in males with Down syndrome can be improved with exercise, particularly resistance training. And there's in our resources, there's a lot of information on exercise and using resistance training, et cetera, to increase muscle mass. And similarly, as we get older, again, it's not well studied in people with Down syndrome, but typically as we get older, we lose muscle mass, and that certainly has a lot of implications for our strength and our balance and falling and other things. And so it's something at a young age we want to continue to address in people with Down syndrome as just as we would in anyone else. Obesity in comparing men and women with Down syndrome. So males and females with Down syndrome. Females with Down syndrome have a higher rate of obesity than males, and overweight is a little less than females, but that's probably mostly accounted for because obesity. So overweight is, sort of it's a step up from weight up from not quite normal, and then obesity is one more step up towards being heavier, and a lot of that is based on the body mass index. So obesity affects both males and females with Down syndrome, but occurs more frequently in males. But certainly we want to be addressing this in all individuals. Another common question is autism. And so we know that autism is more common in people with Down syndrome. In a 2025 study, it was 6.6% and even as high as 16% in another study from 2015. So there's certainly it's higher than in people without Down syndrome. In the non-Down syndrome population, again, this is in people without Down syndrome, autism is 4 times more common in males compared to females. But in children with Down syndrome, the data are mixed. Some showing females tend to be a little more common than males, and others the other way around. So, males more common than females. So it's a little less clear. And then one study, at least one study showed that there was a similar frequency. So it's not as clear in people with Down syndrome compared to the rest of the population. So people with Down syndrome can have autism, and it is unclear if there's a difference in frequency between males and females. And it should be noted that, particularly for a lot of folks that are adults now, the diagnosis of autism is really not that old. I mean, it's really was not discovered or at least clearly labeled until back in the mid of the last century. And then recognizing that it could be co-occur with Down syndrome is even much newer, even in the last 30 to 40 years, probably at the most. So for a long time, it was felt that autism could not occur in people with Down syndrome. And we now know that that's not the case, that it can occur. And so really still a lot of study that needs to be done on autism in people with Down syndrome. As far as mental health, adolescent males with Down syndrome tend to have more behavioral problems than female adolescents with Down syndrome, and also compared to males without Down syndrome. But the data are pretty limited as far as rates of mental illness by sex, how it presents, and whether it presents differently, how you might prevent it, how you might treat it. Are there differences versus males versus females with Down syndrome? So really not a lot of data on this, unfortunately. We do know that as far as presentation, males with Down syndrome tend to have a little more problems with aggressiveness than females. But again, that would not be significantly, as far as we know at this point with limited data. Certainly that's an issue in males without Down syndrome as well when it comes to mental health issues. And so again, some of that may be related to testosterone and other factors. But again, not well studied in males with Down syndrome. So with limited data on differences in mental health by sex, it is important to continue to assist all people with Down syndrome to promote their mental health, really not excluding males or females, because this is an important topic for both. And then another common question is with regards to, do males and females have differences in Alzheimer's disease in people with Down syndrome? So a United States study looking at data from 2011 to 2019 found no significant difference between males and females with Down syndrome. And the average age of onset was about 54 and a half, and the average age of death was about 59. And so again, no difference between males and females in that study. One study did show, however, after age 60, males were more likely to develop Alzheimer's disease. There's also data that suggests that males may have a slower neuropathological progression, meaning that if you look at the brain, the changes that are going on in the brain. And particularly, there's something called tau pathology, which is one of the features of Alzheimer's disease when you look at the brain microscopically. And so that seems to be progress in males more slowly than in females. But again, all the implications for that are not clear. More study being done. So Alzheimer's disease is unfortunately quite common in people with Down syndrome. Regardless of potential sex differences, there's an ongoing need to better understand the cause or causes of Alzheimer's disease in people with Down syndrome, as well as the treatments and prevention. So I'm going to shift now to promoting health and to really I get asked this question a lot in the office. What can I do? A family member will come in, or a person with Down syndrome will come in. What can I do to optimize my health as I continue to age? And are there differences for males versus females? So we're going to kind of focus on two different recommendations, if you will. One is the global guidelines, the global medical care guidelines for adults with Down syndrome. And we're going to, you'll see in the upper right corner, if it's from the global guidelines, it'll be highlighted in yellow. And then when the global guidelines doesn't cover all health topics at this point, although there's another version, round two, I call it, round two coming out, hopefully later this year, early next year, hopefully. So it doesn't cover, so there will be more topics covered when that comes out. But in the meantime, what are the recommendations for the topics that have not yet been covered by the global guidelines? So that'll be, we'll call that ADSC, and we'll highlight that in green in the upper right-hand corner. So we recommend an annual physical exam, and we want to encourage a thorough history and physical exam. We want to include the person with Down syndrome as much as possible in the history taking and the exam and the discussion. So we've borrowed from a lot of different topics, or a lot of different sources, organizations, the different ways that you can fill out with the person with Down syndrome ahead of time, or they can fill it out. Ways that they can express what their concerns are going into the appointment, and that can be shared with the health professional. There's also something called the My Health Passport, which kind of lists a list of things that how the person responds to pain, how they respond to interventions, how they do with X-rays and CAT scans and things like that, what medications they're on, all sorts of things that the individual with Down syndrome can share their history. Any of us, as we go to the doctor's office, we have things we think about, we get nervous, and then we come out of the appointment and go, I forgot to talk about X, Y, or Z. And this really helps people organize that. The other thing in our annual physical, in our information visuals for medical appointments, we have some of the tests that might be done, or some of the procedures that might be done in the office, and how the person with Down syndrome can kind of prepare themselves for that by looking at these visuals and learning what to anticipate, knowing what they can anticipate. So the global guidelines recommends, again, we talked about obesity, recommends monitoring the weight annually and calculating the body mass index. And there are a lot of apps and whatnot that you can calculate the body mass index. It's a complicated mathematical problem. I never calculated it myself. I always use the apps. And then the recommendation is to follow the United States Preventive Service Task Force behavioral weight loss intervention to prevent obesity-related morbidity and mortality. So what we're doing, and again, you see in the upper right-hand corner, this is the Adult Down Syndrome Center. So what our approach, now we're looking more and more at using the principles of lifestyle medicine, including nutrition, physical activity, stress management, sleep, social connection, and avoiding risky substances, which are what are called the 6 pillars of lifestyle medicine. And also looking at medications. And we won't go into detail here. We have some of this on our website, and hopefully we'll be sharing more information of that going forward. As far as diabetes, the global guidelines recommend regular screening for type 2 diabetes. Type 2 is in the past was called adult onset or non-insulin dependent diabetes. We're now seeing the adult onset is not a great term really anymore, because we're seeing more and more young people with and without Down syndrome, in childhood developing type 2 diabetes. We know that type 1 diabetes, where there's a insufficient amount of insulin, we know that's more common in people with Down syndrome. That's typically onset in childhood, although it can be later. But there really is not a screening recommendation for type 1 per se, but for type 2, which is oftentimes related to obesity and inactive lifestyle, et cetera, as well as family history. So the screening for that is the global guidelines recommend starting at age 30 and then screening every 3 years using a hemoglobin A1C, which is a blood test, or a fasting plasma glucose, so a sugar test. And if the person is obese, starting younger at age 21 and then screen every 2 to 3 years. Now, it's not part of the guidelines, but there's more information now coming out that the hemoglobin A1C may be less, the accuracy may be less clear due to differences in red blood cells of people with Down syndrome. So again, if you're going to screen with the hemoglobin A1C, probably good to include the blood sugar as well to get a better sense of that. Thyroid problems are significantly more common in people with Down syndrome. And the global guidelines suggest or recommend screening every 1 to 2 years with a blood test. And it's typically recommended to screen with a thyroid stimulating hormone test, the TSH. I personally have found that adding a T4, which is another thyroid blood test, using a T4 and TSH and looking at the combination, I find helpful as far as screening and diagnosing thyroid problems, but that's not the recommendation is to do the TSH. Additional blood tests, and again, not part of the global guidelines, but that we consider at our clinic would be a complete blood count. And that'll be looking for things like a low white blood cell count, which is more common in people with Down syndrome. Not really a screening tool for leukemia, but certainly if someone had leukemia, that would show up in the CBC. And again, looking for anemia, large red blood cells, and other changes that you might see. Again, a chemistry panel, again, we typically recommend that annually, and then looking at the kidney function and liver function, both of which seem to be more commonly affected in people with Down syndrome. And then a vitamin D level. Again, we tend to do this periodically or based on symptoms. Vitamin D deficiency is more common in people with Down syndrome, and it's important for bone health, and it can also have implications for mental health. Celiac disease, which is the sensitivity to gluten, which is a protein in wheat, barley, and rye, again, is significantly more common in people with Down syndrome compared to people without Down syndrome. So again, this is not a male difference versus female difference. This is just differences in people with Down syndrome in general, but it's certainly something we would recommend for males as well as females. The global guidelines recommend screening annually by assessing for signs and symptoms of celiac disease. And there is a very long list of celiac disease symptoms related to celiac disease and health issues that can be caused or contributed to by celiac disease. So it can be a very lengthy list. So at least the global guidelines do not recommend any blood work screening for celiac disease. They do recommend screening for these signs and symptoms. But again, the list of symptoms is long, and we often end up getting the blood work for celiac disease because the person has one of those symptoms. Now, some organizations do recommend a regular annually or every few years or whatever, a blood test screening for people with Down syndrome, but there are not data that clearly show benefit exceeds the risks or negative outcomes of that. So at this point, there's not a clear-cut evidence-based recommendation to do the blood work screening. Not saying don't do it. Clearly, there's some organizations recommend it and some don't. So there's clearly some differences of opinion on that. Atlantoaxial instability, which is in a sense the slippage of the first vertebrae in the neck on the second, so it kind of wanders off course, if you will, and then ultimately what can cause it can pinch the spinal cord. And so what the global guidelines recommend assess annually for signs and symptoms of spinal cord impingement. The spinal cord being pinched potentially by this movement of the vertebrae in the neck. For adults with Down syndrome without symptoms, the global guidelines recommend against or don't recommend routine cervical spine X-rays. That's one of the ways that in the past it was regularly screened for these lateral X-rays done in flexion, with your head down, and extension with your head tilted back. But it is recommended annual screening using this targeted history and physical exam, looking for symptoms and also findings on the exam that would suggest that this is a problem. The other place where this comes up is should we be doing X-rays before someone has anesthesia, has surgery? And so the recommendation at this point, both in the guidelines and by others, is that doing an X-ray before surgery, and if it's negative, it's normal, that does not preclude that the person's neck could be injured by tilting the head back during typically when the person's being intubated, when the breathing tube is being put into the throat. So the recommendation for all people with Down syndrome, regardless of what their neck X-rays show, would be that you approach them in the operating room as if they have, presuming they have atlantoaxial instability, even if they don't, and not tilting their head back when you're putting the breathing tube in. And there's a way to put the breathing tube in with a scope rather than tilting the head back for directly visualizing the cords, the vocal cords to put the tube in. So again, really it's recommended for all people with Down syndrome not to tilt their head back when they're intubated, when the breathing tube is being put in. So for mental health, the global guidelines recommend an annual review of behavior and mental health. And an important point here is that there is a sort of the euphemistically called the Bible of psychiatric diagnosis is the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5 TR. And there's a companion one that's called the Diagnostic Manual for Intellectual Disability, which changes the diagnostic criteria somewhat because oftentimes in people with Down syndrome and other intellectual disabilities, rather than a self-report of symptoms, it's more of an observation by family members or others of what the change in behavior. So the diagnostic criteria are a little different. And so that's a helpful thing to use when reviewing behavior and mental health. And the other thing is a big issue is we want to make sure we're assessing for physical health causes or contributing factors. We know that many people with Down syndrome who develop psychiatric or psychological changes, that physical health problems are either a cause or a contributing factor to that. So we want to make sure we're looking for those, and that's in the guidelines. We know that children with Down syndrome are a significant number, of maybe 50% or so, are born with congenital heart disease, some abnormality of the heart when they're born. And for all those individuals, it's recommended they get continued regular follow-up with a cardiologist, even through adulthood. We do know that there are some complications down the road potentially that are more common, such as stroke, rhythm disturbances, arrhythmias, heart failure, and what's called non-atherosclerotic causes of ischemia. And what that means is for most of us, if we are develop a heart attack, a myocardial infarction, most of that's because the arteries to the heart are narrowing and there's not enough blood supply. That is less common in people with Down syndrome, but it's more commonly, for example, if they had a congenital heart disease and there's an area of the heart that is working harder, despite the blood vessel providing what would be typically adequate blood supply, that part of the heart may actually have more demand for blood and oxygen. And in that situation, if the heart is stressed, then they may have a heart attack, despite the fact they don't have a narrowing of the artery. So there are some causes of ischemia or heart attacks or angina, you may have heard that term, that occur that are often not related to the cholesterol and the plaques that are so much of a concern in the rest of us. So it is recommended regular follow-up with a cardiologist, if possible, with someone. There's now a subspecialty of cardiology called adult congenital heart cardiology, and those people specialize in care of people that had congenital heart disease or the heart disease at birth, like so many people with Down syndrome do. Also recommend about every 5 years, starting at age 40, have a lipid panel drawn, looking at the cholesterol, and again looking at using what's called a 10-year cardiac risk calculator to help determine possible need for cholesterol-lowering medications. And again, even though this atherosclerosis is lower in this hardening of the arteries is lower in people with Down syndrome, we don't have clear data that tells us we should just ignore it. So at this point, this is what the recommendation is. And again, you use this calculator, and the cardiologist or the physician or the health professional can show that to you. We do recommend considering stopping at age 50. That's not a global guideline, but that's our own guideline, just because we know that based on life expectancy, that the benefit potentially to treat someone older than that with cholesterol-lowering medication may be less clear. And again, this is not a global guideline. This is ours. We recommend a vision exam every 1 to 2 years, particularly looking for some of the conditions that are more common in people with Down syndrome. And there's more interest in something called cerebral visual impairment, which I won't go into, but that's also, we have some information on our webpage, something to consider further evaluation for as well. Hearing, again, not in the global guidelines at this point, but consider hearing testing every 2 years. And again, we know that hearing impairment is more common in people with Down syndrome and occurs at a younger age. And also, it's real important to make sure we're checking for reversible causes, even something as simple as cerumen or earwax impaction blocking the ear and contributing to poor hearing. And again, we talked about the testicular exams, again, not in the global guidelines yet. So we do recommend an annual testicular exam at our clinic. And again, not in the global guidelines yet, but we do typically recommend, we see a lot of musculoskeletal problems, pes planus, which is flat feet or overpronation where the ankles turn in. There's a lot of joint laxity or instability in people with Down syndrome, as well as osteoarthritis. So if there's any concern about that, we will typically refer to a physical therapist to get a good evaluation and get some recommendations on ways that the musculoskeletal system can be optimized despite these other challenges. One important thing is that we often see musculoskeletal problems present as a change in function or behavior rather than pain. So someone may have severe arthritis of the knee, for example, and they're not complaining of knee pain like many of the rest of us would, but they're not walking as well. And so you want to make sure that that's being appreciated. That can be part of the issue there. Sleep apnea, again, at this point, not part of the global guidelines, but again, sleep apnea can cause sleep apnea in people with Down syndrome is typically obstructive sleep apnea, where the brain is telling the body to breathe, but the airway gets obstructed during sleep. And so the air is not moving in and out of the lungs appropriately. So it was not addressed in the 2020 guidelines. It can cause all sorts of health problems. And so certainly gaining weight can increase your chance of getting sleep apnea. Certainly some of the symptoms include mental health changes, restless sleep, daytime fatigue, impaired cognitive skills. So there's lots of reasons you might consider repeating a sleep study. Presumably it was done in childhood. You can get repeating a sleep study in adulthood. And again, so even if you did not have sleep apnea as a child, you can develop it as an adult. And then cancer screening, we've talked about other cancers, but both colon cancer and prostate cancer are less common in men with Down syndrome. So the benefits and risks of screening are undetermined. So that's, again, something to discuss with your health professional. Again, it was not in the 2020 version of the global guidelines. And then what was discussed, one of the things that was discussed in the 2020 guidelines was osteoporosis. And there really is insufficient research at this point to recommend screening bone density and getting DEXA scans in men or women with Down syndrome. However, if an adult with Down syndrome has a fracture that looks like it's due to osteoporosis, you do want to assess for potential contributing causes such as celiac disease, hyperthyroidism, vitamin D deficiency, a number of these things that are more common in people with Down syndrome. And then for Alzheimer's disease in the global guidelines, it's recommended to take care to avoid overdiagnosis in adults younger than 40. So both men and women with Down syndrome are unlikely to get Alzheimer's disease before age 40. So we want to be careful not to be diagnosing 25-year-olds, 30-year-olds with Alzheimer's disease. We really want to make sure that we're looking for other causes, even in the older folks, but particularly in the younger folks. And it is recommended in the global guidelines at age 40 to start annual screenings to look for changes, cognition, behavior, communication, other things, and that could be symptoms of Alzheimer's disease. And again, there's a nice tool called the National Task Group Early Detection Screen for Dementia, NTG-EDSD, and that's available when you get the slides, you can click on there and find that. So what are the key takeaways? get to the point where we really want to get some questions. We want to understand the unique health needs of males with Down syndrome, help ensures appropriate screening, early detection of health concerns, and personalized care across the lifespan. So we're looking at these differences and what does that mean with regards to men versus women or men with Down syndrome versus men without Down syndrome. Males with Down syndrome share many of the same health concerns as males without Down syndrome, but some conditions occur at different rates and may require a different screening approach. Regular screening, annual physical exams, and attention to changes in health, behavior, and function can help identify concerns early and potentially have a significant benefit. Just because the person has extra chromosome, extra 21st chromosome, we don't want to assume that there's not things that we can't, we want to assume that there are things we can do to impact that and to change the outcome of that person having the extra chromosome from a health standpoint. Healthy lifestyle habits, including physical activity, good nutrition, adequate sleep, stress management, these all play an important role in that promotion of well-being. And healthcare decisions should be individualized and guided by current recommendations, personal health history, and a discussion between the person with Down syndrome, their family, and healthcare professionals. So just real quick, and I'll run through, Laura mentioned our resource library. Please feel free to take a look at that. A lot of good information there. We have within that, our webpage, we've included links to a number of things you might be interested in based on what we talked about today. So when you get these, you can find them easily with clicking on that. And there's also a nice search engine on our webpage that you can use as well. Our mental wellness book is available free as a PDF on our webpage in both English and Spanish. Again, please feel free to use that. All the information on our webpage is free as long as, if it's a journal article that you have to buy a subscription, that then we don't have for free, but everything else is free. Another free resource is the Care Down Syndrome that I was very involved in with the National Down Syndrome Society. The focused audience is healthcare professionals, particularly primary care physicians or clinicians. So certainly something you can share with them, but it's certainly very usable by families as well. And so it has a free a 2-hour course, reference articles, and a lot of resources. And again, health professionals need to do continuing education, and oftentimes that's costs them. And this is all free for the health professionals. And then additionally, there's the Down Syndrome Medical Interest Group. Again, this is for healthcare professionals. Certainly, if your healthcare professional is looking for more information, this is a good resource. And there is something called Project Echo. If you don't have access to a clinic or you're looking for your health professional is looking for some specific guidance, Project Echo allows the health professional to present what's called a de-identified case, so they don't identify the individual with Down syndrome. But then there's usually 25 to 35 really experts in Down syndrome on the Zoom meeting, and then we share information with that health professional, and in a sense they can take that home to treat that individual. We have a number of primary references in the medical literature if you're interested, and I'm going to stop and we'll do some questions. Sorry, that went a little longer than I intended, but a lot of good information.
Yes. Thank you so much. And we have received just so many wonderful questions. We will stay after a little bit longer, and we are recording the webinar. So if you can't stay, you'll be able to hear the full Q&A and the recording. So since we have so many, I'm going to dive right in. Can you clarify with testosterone, is it the low testosterone or taking testosterone that causes aggression?
So I am not aware of any data that says the low testosterone contributes to aggression, but we do know that in some people that are taking anabolic steroids, that without Down syndrome, the testosterone and others, that aggression can be a potential complication. So it's not a universal thing, and it may not be a significant issue. We just don't have a lot of data on but it is a theoretical risk from taking the testosterone.
Okay. And then can low testosterone affect mood?
That is a good question. I don't know that we really have a good answer to that question in people with Down syndrome.
Thank you. We got some questions about undescended testicle and risks of testicular cancer. So if a male with Down syndrome had an undescended testicle and then they had the surgery to bring the testicle into the scrotum as an infant, do they still have that increased risk of testicular cancer?
Yeah, so um, there is a risk from having Down syndrome itself. And so that by bringing it down, that hasn't changed. So theoretically, bringing it down, there's some debate on this in people without Down syndrome, but bringing it down does seem to reduce the risk from having it be undescended. So you do get that benefit, but you don't change the fact that there's an increased risk by having because the person has Down syndrome. So there's still that issue. On the other hand, the testicle is now very you can check it very easily during a physical exam. And so if there is any change, you should be able to pick up on that. You know, to that change, you don't need to do any fancy x-rays and whatnot right up front. The first part is pretty simple, just part of a physical exam. So it's, as long as that's getting done.
And what kind of symptoms or, signs should families watch out for?
So oftentimes it's pretty asymptomatic, meaning there's not symptoms. Just as the testicle enlarges, there just mean just discomfort because it's bigger. Um, um, so that would be something that might be noticed. We've people seen it gets large enough that people start walking differently just because it's in the way, if you will. And so those would be some things that um, you might notice. And again, particularly if there's a small change, there may not, there may be nothing that the only way you would really know is if you're examining it regularly. That comes in all sorts of other issues with regards to privacy and independence. And so that's again part of the reason that we really push to do this in our office annually.
And is that exam something that a primary care physician can do, or should someone see a specialist?
No, that is definitely something the primary care physician should be able to do. I mean, that's kind of bread and butter primary care.
Great. If a male had an undescended testicle and it was removed in infancy, would that still be an indicator of increased risk of testicular cancer in the other testicle?
Uh, probably not the probably not the undescended testicle component of it, as long as the one that's still there was not undescended. But certainly the increased risk from having Down syndrome, increased risk of testicular cancer because the person has Down syndrome is still there.
Okay, thank you. Um, for kind of what's your general approach when someone can't cooperate with some of these screenings that we've been talking about, like testicular exams? Do you recommend having them done under anesthesia or sedation?
I think we really try very hard to get them done in the office if at all possible. So we use, strategies to, relaxation strategies. We use, um, you know, pictures, here's what we're going to do, just to try to help the individual be comfortable with that. Um, if you've done all those things and it's still not possible, I think we do consider the possibility of doing some of these things under anesthesia, but we really try to lump it together. I think I'd be hard pressed to recommend someone have general anesthesia just to do a testicular exam. I think the risks of that would probably exceed the benefits. It's still an issue, but it's not a really, I mean, it's not so common that I would recommend we start running every man through Down syndrome to the OR to get this tested. So in that situation, if the person's going to have a dental exam under or dental treatment under anesthesia, can we get the physician or someone in there to do the exam just before or after the dental procedure? Same thing with blood work and whatnot. I don't typically just recommend people get anesthesia just to get blood work, but if they're getting anesthesia for something else, if they need some other surgery and they're going to be going to the operating room anyway and get anesthesia, can we kind of lump all these things into the same exam?
Thank you. Um, we received some questions about supplements. Are there any that you recommend for males with Down syndrome? And then also specifically, if you recommend vitamin D3, how much do you recommend for an adult male?
Yeah. So we'll often recommend vitamin D, particularly if the vitamin D level is low, although some people would recommend that even if you don't even test it. So we typically don't recommend above 2,000 daily, 2,000 international units daily. which would be in line with the recommendation for the rest of the population. Um, Other supplements, there really is just not good data on a lot of this. I mean, people are looking at a lot of different things. There may be animal studies, or there may be what are called in vitro studies, where you're looking at this how cells react in a dish, not in the person. So there is some data, but really not a lot of good data in people with Down syndrome. And so I don't think there's any hard and fast recommendations at this point I mean, there's a lot of different opinions, but that's what our approach is. There are some data in the non-Down syndrome population that a good multiple vitamin may actually have some benefit with regards to life expectancy. So I think a good multiple vitamin, and particularly vitamin D, would be the kind of two things that I would think of off the top, right off for anybody.
Okay, thank you. Um, Received a question about if a male with Down syndrome has a cyst or a spermatocele, if I'm
Spermatocele, yeah.
spermatocele on one testicle, should that be followed up on regularly, and is it recommended that it be removed?
So, so these are typically what's being described are changes that are outside the testicle, and that's an important thing to delineate. So if you have a mass in the testicle versus a spermatocele in the cord that goes down to the testicle, that's a good way to delineate that, this is not testicular cancer if it's not in the testicle. So that's one thing. I mean, to clarify it, if it's not clear, I might order an ultrasound just to clarify where exactly it is. That can be really helpful. But certainly again, ongoing regular exams. And if there's any question, where it is, we would err on the side, because testicular cancer is more common, we would err on the side of getting the ultrasound just to know for sure what we're dealing with. Um, but otherwise, regular follow-ups by exam. And again, sometimes, periodic ultrasounds may be indicated as well, depending on what you're feeling and whether it's growing or whatever.
Thank you. There was a general question about the statistics shared during the webinar. Are those applicable to people with Down syndrome, mosaic Down syndrome?
Yeah, that is a great unknown question. I mean, it's a commonly asked question, but I don't think there's as good. So there's a lot of data that we just don't even have for Down syndrome in general, and then even less when you break off a part of the population, pretty small part of the population, 2 to 3%. So I think there's a lot of information we just don't have. So in theory, uh, and in some things that have been studied, uh, the either the risk of getting something or the severity of things tends to be less in some people with mosaicism. But a lot of that's theoretical at this point without solid data to support it.
Thank you. We received some questions about cholesterol and statins, and I know you had done a podcast episode with Dr. Velody at the Down Syndrome Center of Western Pennsylvania, and it's a complicated question. So I'll make sure to include the link to that in the email with the recording. But is there anything you want to highlight about that topic?
I would say that again, there's insufficient data at this point to make real definitive recommendations. But I think that was about a 20 or 30-minute podcast, and so I really can't do justice. I would agree with Laura. I would recommend taking a listen to that podcast because I did a lot. I did a lot of not only what we've been doing day in, day out in our office, but I also really went back very thoroughly and looked at all the literature that's available and used that in that podcast.
Thank you. Regarding colonoscopies, is there a way to do a colonoscopy without doing the prep? That's not Cologuard. The question indicated that Cologuard had failed.
Yeah. No. In fact, one of the if you look at studies, for example, if the person is not well prepped, they don't even include that. I mean, you just don't get the information. You can miss things very easily if the person's not well prepped. So you really do need to do the prep. really, again, the risk of getting colon cancer in people with Down syndrome is really much lower than it is in the rest of us. And so, again, looking at, and a lot of times not only is the prep a challenge, but the getting the test, sometimes people have to have that done under significant anesthesia. Now, most people have it done under sedation, but some people with Down syndrome have to have significant anesthesia to get that done. And so, the risk of the procedure is higher because of the anesthesia, because we know that people with Down syndrome have more risk for anesthesia than the rest of us. And then, the frequency of the disease is quite low. So the benefit is lower and the risk is higher in people with Down syndrome. So that's something to really discuss on um, you know, how comfortable are you potentially to miss the one rare case or a couple rare cases of colon cancer versus putting a large number of people with Down syndrome under the risk of anesthesia? There's not a real clear answer to that. So that really is it worth a discussion.
Thank you. Would you mind clarifying at what age and at what age range that you recommend testicular exams for men?
Yeah, I think, certainly 15 to 35, but even 15 to 45, 15 to 40, I think would, definitely 15 to 35. That's probably the most common age range, but I think at least up to 40, I would probably maybe even 45.
Thank you. We also received some questions about urological issues. Are those things you tend to see in males with Down syndrome, and are they different in males versus females?
I think by and large, we have seen urological problems in both men and women. I don't know that we really have data to tell us that it's, great. I mean, obviously, prostate and testicular, obviously, you're not seeing those in women, male, female, obviously, um, uh, but things like urinary retention, difficulty emptying the bladder, bladder infections, maybe bladder infections probably a little more common in women or females with Down syndrome, just because that's, also more common in women, females without Down syndrome. But by and large, I would say that the either we don't see differences or we just don't have data to tell us there's differences.
Thank you. We did receive many questions about GLP-1s, and we're planning to do another webinar with Dr. Katie Frank and Dr. Shelley Verma from our office later this year on lifestyle medicine and GLP-1s. So just wanted to let everyone know that there are also some resources in our library, podcast episodes on this topic. Again, it's a little bit more than we probably have time to get into today, but I just want to acknowledge that we did see those questions and we are planning to share more information on that as well. I'm sorry, there are so many amazing questions. Are there any skin conditions specifically in males with Down syndrome, or just any general information about skin?
There are not much data to tell us the sex difference, men versus women. I mean, there are some things that seem to be related to, differences in female hormones throughout the menstrual cycle. So that there might be some differences there. But in general, I think that sort of like Alzheimer's in general, there's just a lot of skin conditions that people with Down syndrome have, males or females. And so there's on our website, there's also, again, the Western Pennsylvania group did a couple podcasts with, can't remember which dermatologist it was, but
Dr. Jillian Rourke.
yeah, I mean, Dr. Rourke, she's fantastic. She gives a lot of good information. So I'd encourage you to, if you have more questions about, I think, in fact, there was so much, I think they did a two-parter, if I'm not mistaken.
Yeah, they did.
So lots of good information about dermatology. We have some information on our website as well. There will be more information coming on in Care Down syndrome on dermatology as well. So
fantastic.
Stay tuned.
What are the risks or negative aspects of doing the celiac blood test screening?
Yeah, that is a great question. So the benefits potentially to doing screening, the blood, I mean, checking for the symptoms, I think is that makes sense because if someone has symptoms, you'd certainly want to treat that. So that, I mean, hopefully find that or assess for that and then treat it and hopefully improve the symptoms. Assessing someone that's not having symptoms is a little less clear. So on the do it side, if you can treat it and reduce inflammation and reduce the activation of the immune system, that may potentially have some benefits. And although that again, that's not well studied, particularly in people with Down syndrome, but that's a theoretical benefit. Some of the downside would be, well, let me go back a step. In people without Down syndrome, one of the reasons that they recommend looking for celiac is because it's associated with increased lymphoma in the gastrointestinal, in the small intestine. But that's not really found to be an issue in people with Down syndrome. Again, probably based on the low solid tumor rates in people with Down syndrome. So that benefit is really not as clear, or it doesn't seem to be an issue in people with Down syndrome. A negative would be, again, if someone's not symptomatic and you say, okay, I'm not quite sure that this reducing the inflammation really is going to have a benefit. Again, some debate about that. So now I'm really sort of the whole family's having to deal with a celiac, a gluten-free diet, which can be challenging. I think the other issue we have found with adults with Down syndrome is that, we're working to promote independence and being out in the community and stuff. And sometimes that gets bogged down by trying to follow a gluten-free diet. So if they're not getting clear benefit, but and now they're bogged down by that, that can be a challenge. So I think that by and large, the sense is there may be benefit to treating even if someone's not having symptoms, but it's not clear, and that's why the global guidelines are listed as they are. And other organizations, again, there's a mixed bag depending what organization you read.
Thank you.
Also, one other thing is it's probably becoming less of an issue, but certainly when we looked at this a number of years ago, the cost of gluten-free food was significantly higher as well.
Thank you. Are the rates of testicular cancer higher for individuals with Down syndrome or males with Down syndrome who had leukemia as a child, or is that not known?
That's a good question. I'm not aware that that's clearly known.
Okay. Thank you. I know we have gone over and you've graciously stayed an extra 15 minutes, and I wish we could answer all these wonderful questions. Unfortunately, we are going to have to stop for today, but we really thank all of you for joining our webinar today. And please check out our resource library. There's a lot of information on there, and stay tuned to our social media and our email newsletter. We'll be sharing more information about other upcoming webinars. We have 2 more planned for 2026. So thank you all so much, and we hope you have a great rest of your day.
Thank you for joining us.